Hi everyone, I'm Dr. Toussi. We're here to talk about lumbar spinal stenosis. I did a similar presentation of this approximately 2 years ago. Some of you may have seen. That one was really focused on the mild procedure. For this presentation, I've included the mild as well as other relatively common treatment options that we use for spinal stenosis. The goal of this presentation is to give a general overview of causes of low back pain, discuss the anatomy related to lumbar spinal stenosis, discuss what an office visit can look like and what you can do to optimize your time during that office visit, and then discuss available treatments, which include medication, physical therapy, injections, mild and potentially surgery. Many causes of low back pain. This list by far is not comprehensive, but you have your degenerative disc disease, lumbar radiculopathy, pain related to your facet joints, sacroiliac joint pain or SI pain. You can have muscle pain or what we call myalgia, and then lumbar spinal stenosis. Degenerative disc disease is a fairly common thing we see on X-ray. It can cause pain itself and can lead to other causes of low back pain as that cushion in between your vertebrae begins to thin. It can lead to narrowing on the sides where the nerves come out. We call the neuroforamen, or narrowing in the center. And it can also, the discs themselves can become painful. This can be somewhat of a challenge to treat. And we have lumbar radiculopathy. This is when a nerve is irritated in your back going down the leg. There's multiple nerves from L2 to S3. These nerves generally follow a specific pattern. A lot of patients and people refer to this as your sciatica pain, which technically isn't true. Your sciatic nerve is made of multiple nerves from your L4 to your S3, but will generally follow the S1 and the L5. And we have lumbar facet-mediated pain. These are your facet joints. They're like little knuckles in your back, and they can get arthritic, grow, and be painful, just like any other form of arthritis. You can hear a lot of cracking, popping. It can also be related to stiffness in the back. And a lot of people will tell me as the weather changes, this back pain gets worse as well. Then we have muscle pain. Usually when people have muscle issues, it's due to an underlying spine issue. Your body's way of protecting the spine is to tighten up those muscles, which can lead to spasms, and they can also become a separate source of pain themselves. If you also have nerves irritated in your back, those nerves also go to the muscles and can lead to spasms in your buttock muscles or your leg muscles. Your sacroiliac joint, this is essentially where your tailbone and your pelvic bones come together. A lot of people will present to me and tell me that their hip hurts in the back or they have a lot of gluteal pain. Most of the time, the SI joint can be the culprit. So the topic of this conversation, lumbar spinal stenosis, affects a lot of people. It is a degenerative process affecting approximately 20% of people over 60. There's 2.4, if not more, people in active treatment on a highly prevalent condition. I'm going to try to use this model to kind of show you when we talk about stenosis. Stenosis just means narrowing. So we're either talking about narrowing in this hole here, which we call the central canal, or narrowing in the side, which we call the neuroforaminal canal, where those nerves exit. You can see from the pictures here, you can see that there's depicting the neuroforaminal narrowing, and then we have our cross-section view all the way to the right, where you can see the central canal narrowing, and there's multiple causes of that narrowing, which we identify with an MRI, but it can be related to disc bulges, thickening of the ligament, bony overgrowth, spondylolisthesis or slipped discs, or just worsening arthritis of those facet joints. What does your lumbar spinal stenosis patient look like? They have severe diminished mobility and quality of life. We call it the shopping cart sign because people will require the shopping cart to lean on, despite of how much they need to buy. As they stand and walk, they start getting worsening low back pain, then hip pain, and then it might progress to the legs and weakness. At that point, they start looking for things to lean on or a chair Lumbar spinal stenosis patients are generally pain-free sitting or leaning forward. They'll find themselves sleeping in kind of the fetal position or with pillows under the back and under the knees. And I've had patients tell me that they've been sleeping in their recliner for years because that's the position that opens up that narrowing in the spine. Next slide. So what's an office visit going to look like? I think I put this slide in here because, I think it's important for patients to know how to really optimize their visits. When you come in, we're going to get a history of your symptoms, history of current and past medical problems, and history of treatments to date. This is really important to us. It keeps us from repeating treatments you've already tried. You may qualify for certain treatments if we can get documentation for the insurance company. And then we also want to review available imaging. Here at OrthoVirginia, if you have no x-rays, that's the first thing we'll obtain here at your office visit. Take a gross look at your spine. What should you think about when your appointment's upcoming? Where do you really experience the discomfort on a regular basis? How do you get comfortable? Is it sitting? Is it bending? Is it lying down? Is it laying to one side versus another? How long can you stand for before you need rest? How long can you walk for before you need? And really, what activities in your life is it starting to interfere with? The only way to really diagnose lumbar spinal stenosis is with an MRI. For that MRI, we're going to look to see what is the severity of the stenosis. What are the causes of the stenosis? Are you having thickening of the ligament? Do you have a slip disc in your back or a spondylolisthesis? Are there disc bulges? Are there herniations? So we'll take a look at all of those. Really what we're looking at is the severity. This view here, we're looking at progression of severity of spinal stenosis. Just as a clarification, we are looking into the spine just like that. And if you can see those little dots in there, those are the nerve legs. As it gets harder and harder to see those nerves, the severity of your stenosis is getting worse. So treatments. What is the goal of treatment? Obviously to decrease pain. We want to increase mobility, increase quality of life, and to postpone surgery as long as we can. This will include medications, physical therapy, injections. I will review the mild procedure again, and potentially surgery. This by all is not a comprehensive list, but a list of the most common treatments covered by insurance companies to date. In terms of medications, we start with our non-steroidal anti-inflammatory drugs. I'm sure everyone's relatively familiar with these. Our over-the-counters or the ibuprofens and your Aleve, and then your prescription strength medications such as diclofenac, meloxicam. But these medications really, long-term use is shown to increase your risk of cardiovascular events. We want to avoid these in patients with ulcers or GI issues, patients with chronic kidney disease, and patients on muscle. For muscle relaxers, there are several of these: Flexeril, tizanidine, baclofen, methocarbamol, that can treat the muscle pain, and they can treat the muscle pain caused by underlying spine issues. These have multiple mechanisms of action, so just because you didn't respond to one does not mean that another one will not help. Then we have our nerve medications such as gabapentin or pregabalin, otherwise known as Lyrica. You may have also heard Topamax. These are all traditionally used as anti-seizure medications, but have shown to work on nerves in the periphery. And then there's your antidepressant medications such as Cymbalta, Effexor, or your tricyclic antidepressants such as amitriptyline and nortriptyline. And these show to also help with nerve pain. None of these medications are going to change your spinal stenosis. The narrowing is going to be there. Generally, we're hoping that these medications will help you stand longer and walk farther. Physical therapy, this will include core strengthening exercises. As you tighten up the muscles in and around the spine, it allows your spine to work with some help. It can have a decompressive effect. Mobility exercises can also relax the muscles and increase your range of motion. And as spinal stenosis gets worse and nerve compression gets worse, you can start to develop some balance issues. So physical therapy for balance can not only help mobility, but can also prevent falls. Studies have shown that actually working with a physical therapist, people get better outcomes than doing the home exercise program. However, it can be a challenge for patients to go to an appointment twice a week for a half hour to an hour. Patients have transportation issues and just works, kids, and life. Most insurance companies now are requiring 6 to 8 weeks of physical therapy prior to allowing us to order an MRI. One of the treatment options we do offer here are epidural injections in the back. These can be used for multiple causes of low back pain, including discogenic pain, lumbar radiculopathy, and for spinal stenosis. For spinal stenosis, these can be done with and without steroids. Very low risk of complication, but I always tell everyone nothing has the zero risk of complications. Our goal is obviously we'd like it to last forever, but 3 months we consider a decent amount of relief, especially if you're getting improved mobility. We are restricted to how much steroids we can give you, so 3 to 4 doses a year can be given, generally safety without any long-term consequences. The other goal of epidurals is even if you get temporary relief, that helps the surgeon identify which levels to really target and what approach to take. Here are almost always X-ray guided. There's a couple of ways to do the epidurals. The first way is the interlaminar. I try to explain to patients, this is kind of like a shotgun blast. It'll spread up, it'll spread down, it'll spread to the sides. We're going to bathe all your nerve roots in some steroids. We generally start with this approach. However, if you have severe narrowing in that central canal, then we may consider a different approach, and that's your transforaminal approach. If you have severe narrowing, we can make that narrowing worse if we go right down the middle and put more medications in there. So sometimes we do the transforaminal, and that's where we come from this side and into this hole here and put the steroids. If we're doing it for spinal stenosis, we'll do both sides. Occasionally people will have just one-sided pain, or we're concerned about testing one nerve or another, and so we'll target those with transforaminals. Mild procedure. So this is a relatively, I would say, new procedure, going on about 10 years old. From this view here, you can see progression of the narrowing of those channels as we go from left to right. You start seeing disc bulges as well as thickening of those ligaments, causing kinks in those channels. This is another depiction. We see at that L4-5 level, there's also a slight slip the disc forward. We call those spondylolisthesis. And that other view, there is thickening of that ligament, which is the target for the mild procedure. The mild procedure is treating the narrowing of the spine. The goal is to go in and open up that space just a little. It doesn't take very much opening to have a profound effect. We do this with a relatively small incision. It has a safe profile equivalent to approximately an epidural steroid injection. We do this with some mild sedation and a lot of numbing medicine. 2-level mild can take me about 45 minutes. The patients go home that day, they're up and walking that day, and generally we like to get them into physical therapy soon afterwards. This procedure is good for people from early to late disease. Generally, if you have severe stenosis with the spondylolisthesis, I'd recommend you actually talk to a surgeon. It is minimally invasive, and so there are limitations to how much it can open up that central canal. However, I do offer it to patients who are either too sick or too old for surgery or have other conditions. Do this only in the lumbar levels, and if you have a slipped disc in your back, if you have osteoporosis or already hardware in your back, you may not always be a candidate for this procedure. This slide's just to depict the safety profile, and like I said, it's relatively safe, equivalent to an epidural. No history of spine fractures, and without any significant cause of instability in the spine. Cleveland Clinic study showed that after the mild procedure, people were able to stand approximately 600% longer and walk 1,500% farther. That being said, it is not a cure. I always tell the most important thing is to have reasonable expectations with the mild procedure. This is just a depiction of how the mild works. We do make a small incision. It is done under X-ray guidance. We initially go in and remove just enough of that bone in order to get that tissue sculpture in. Once that tissue sculpture in, we start debulking that ligament. The mild procedure works better for that central narrowing, but if you have a significant amount of that narrowing on the side or that neuroforaminal narrowing, cannot address that, and you may be better served with other treatment options. There are no sutures involved and just a Band-Aid. Really, the goal of the mild is to help people stand longer, walk farther with less pain, improve activity level, and improve quality of life. Mild currently is covered by Medicare plans and Medicare Advantage plans, most military plans. Fortunately, at this time, we are finding it a challenge to get it covered by commercial insurances. And then surgery, I want to be clear that I am not a surgeon. We generally reserve surgery as a last resort, and most people have tried and failed all other conservative options. On certain occasions, we may jump to first, especially if the narrowing is severe and you're starting to show signs of nerve damage, like persistent leg weakness, balance issues. Surgery generally involves decompression and opening up of that central canal and those canals on the side. Surgical approaches and technique can vary by the cause of the stenosis, the patient profile, and surgeon training and techniques. Obviously, surgery is not without risk. Some patients may need clearance, and then recovery time can vary by patient characteristics, your age, what other medical problems you have, and as well as the extent of the surgery. Thanks, everyone. Take some questions, and I'll do my best to answer them. I see some questions here.
Thank you so much, Dr. Toussi. We do have some questions coming in, so please feel free to leave your questions in the comments section if you are watching us live on Facebook. We will be answering questions submitted earlier and questions submitted live. We will not have time to answer all the questions, but we will do as many as we have time for. So our first question is, what causes the spinal stenosis? Is it genetically inherited, and is there anything you can do to help prevent it?
So spinal stenosis is multifactorial. Some of it can be genetic. If you have a family history of back problems, degenerative disc disease, then a component of that can be genetic. It can be from what I call wear and tear based on certain occupations people have, how that occupation affects their posture. Is there heavy lifting, heavy pushing, heavy pulling? It's generally caused by either thickening of that ligament, hypertrophy of your facet joints, or enlargement of those facet joints, and disc bulges. I call that the trifecta of spinal stenosis. And in most cases of spinal stenosis, we'll see a little bit of all of that.
Thank you. Can spinal stenosis cause urinary and bowel problems?
It can, but usually in its most severe situations. At that point, if you're starting to develop bowel and bladder changes, we generally skip other treatment options and proceed to surgery.
Thank you. Is walking good, or is it more stressful on the spine?
I always recommend activity and walking around. Now, obviously, if you're walking up and down hills, if you're walking on uneven surfaces, that can stress your spine. And then, if you're walking with heavy weights on your back, on your shoulders, you may not want to do that.
Does nerve ablation help spinal stenosis?
No, nerve ablation is what we use to treat your facet joints. It's not something we can use for spinal stenosis. For nerve ablation, we're generally numbing the nerves that send the pain signal from those arthritic joints in your back to your brain. We start that as a diagnostic injection to see if your pain goes away. If it does go away, then we bring you back, lay needles on those nerves, and burn them.
What is the best position for sleeping if someone has lumbar spinal stenosis?
In most situations, it's either sleeping on your side in the fetal position with pillows between your knees, or sleeping on your back with pillows under your knees. The position of comfort for spinal stenosis is when you're bent forward, and so maintaining that position in bed usually allows people to sleep a little bit longer.
Are there any age restrictions on the treatment for lumbar spinal stenosis? Do you have to be under a certain age to do the mild procedure?
No, in actuality, that we're doing this procedure more and more in older people because they're just not candidates for big, large decompressive surgeries. The bigger challenge is doing it in younger people because they don't have Medicare and it's not covered by commercial insurance.
Are TENS units helpful to manage the pain?
They can be helpful. Generally, TENS units are treating the muscular component related to the pain. But anything you can do that doesn't require medications, I always consider a success.
Is spinal stenosis progressive, and will it affect other levels?
As we age, we're aging on the inside as well as the outside. So as things deteriorate, spinal stenosis can get worse. And as one level begins to deteriorate or develop spinal stenosis, we start seeing it at other levels as well.
Can spinal stenosis symptoms be affected by weather, the way some people have their arthritic joints affected by weather?
You know what? I suspected I was going to get this question, so I went back and reviewed the literature. And when it comes to low back pain, the literature has not found that the weather can worsen it. Now, there's a little bit of evidence that severe weather can lead to tightening of the muscles, which can lead to worsening pain. It doesn't necessarily mean that it does not. It just means that those studies may not have been strong enough to detect that type of effect.
Who does the injections? Are you doing them?
Yeah, I do. I'm considered a non-operative spine specialist. So I do the injections here. We have 3 other providers also here providing this service.
If an epidural has not helped, is mild still an option?
Yeah, absolutely. Generally I start with the epidurals. I use it for 2 purposes. One, to see if we can just do an epidural and make the patient comfortable and see how long that lasts. But also, if you get just temporary relief from that level, then I know where to focus that mild on.
What types of exercises are recommended? Is swimming better than running, for example, if someone has stenosis?
I think, any type of low impact exercise is preferred over high impact, such as running. So I would say elliptical, possibly the Stairmaster. Swimming is good as well, and exercises that really focus on strengthening.
What is the expected recovery period after the mild procedure? Are there any restrictions afterward?
I always just tell people to kind of take it easy for a week. They're going home within an hour after the procedure is done, and then gradually up and moving. I don't want people laying in bed all week. And then after 7 days, I try to get them into physical therapy to start really re-strengthening the legs, since they haven't been able to stand and walk for long distances and may have some deconditioning.
Would you recommend dry needling for pain relief for stenosis?
I think it can control, once again, just like the TENS unit, it can really address the muscular component of spinal stenosis. As that narrowing gets worse, those muscles are going to tighten up and can become problematic themselves. Dry needling can also be helpful during physical therapy. If the muscles are so painful that you can't participate in physical therapy, the dry needling can be a good stepping stone, open up to other types of treatment.
Are inversion devices helpful?
They can be helpful. It's one of the things I do recommend, but I think inversion tables will work much better along with core strengthening exercises. As you're lying upside down, you will have some decompression and it will cause some relief off those nerves in your back. But as soon as you're right side up again, if you really haven't improved your muscle tone around the spine, it's just going to collapse to where it was.
Does body weight have an impact?
I think it does. If the heavier you are, the more stress it's going to put on the spine. And, I always recommend patients lose weight, and it's not easy to do. I tell patients that those who even try to lose weight are healthier and do better than those who don't. So to try and fail, you'll still do better than someone who does not try at all.
How often do you get an MRI to see the progression of stenosis? Is this something that you need to repeat on an annual basis?
We usually say about every 2 years, unless we plan on having some type of surgery or a more aggressive procedure, then most surgeons will require an MRI that's less than a year old. Or if you start developing new symptoms out of the ordinary, then we may recommend repeating an MRI.
Can acupuncture help?
Acupuncture is an Eastern type of medicine. Initial mechanism is described as reorganizing the flow of chakra points in your body and this flow of energy. I don't think it could hurt. If you do get some relief for it and it's financially feasible for you, then I would say proceed.
Does getting an injection and so not feeling the pain actually make the condition worse at all because you are going to be not taking steps to protect your back?
I get that asked a lot as well. The injection and the numbing medicine from the injection does not last that long. If there is an effect from the steroid, it's an anti-inflammatory effect. And so that effect will also be only present for 2 to 3 weeks. So if you do engage in activity that you're not supposed to, you'll essentially just cause inflammation again, and the pain should return to what it was.
Thank you so much, Dr. Toussi. That is also the time we have. Would you like to close?
Oh, well, thanks, everyone. Come over here. If you have any back pain, we're happy to treat you. We have 4 providers. We treat all different types of back pain. And if there's something we can't do for you, we'll do our best to find someone who can.